So I know it really messes with your head, doesn't it? So if we go to presentation, I'll just double check. It's all good to go.
So the people at home saying,
just see the screen. They want the cameras just there.
Camera.
It's just cameras on the camera will be a little sort of side screen. It's just to show that there's people actually there, because every time I do it, people are always, I can't see anything. But what it is it's me that decides who gets to see what.
Okay.
So the main thing you'll see will be the presentation, and you'll hear the voice. The camera will just be like a little window on the side of the screen.
Right, I see.
So don't worry about
Okay. So if I walk about, will
that. What doesn't matter, as I say, it's just it'll be a little window just so they can see people, so they know there's actually something.
Oh,
So
right.
don't worry, you don't have to be anywhere. That just ignore the fact that the camera's there.
okie dokie.
You can go anywhere.
And this thing I
that's
do,
a quicker, so
that's
that's-
forward?
no,
or
other way.
That's forward
That's
and that's
forward,
back.
yeah.
Okay, and is the pointer thing
The
this
pointer's a
one?
little button on the top, yeah. So if you see this one here, so it's like a little sort of line there.
Oh, sorry, I haven't got my glasses on, that's
All
why
right.
I can't see it.
It's that one, yeah, there you go.
All right, okay. Brilliant. Okie doke.
And don't press button 2 until the light will go off.
All right.
But you're fine, you won't even think of it. You know?
Now you've told me not to.
No.
I will. Okay. Right, let's do some.
Correct. But it's fine. It was easy. That's what I like to hear. I don't.
No one looking through much.
What's happening is
There's an hour space.
I don't know if you'd like
I mean, it's because the live and then she's just
Hi. I'm good.
just that side. Good evening, everyone, and welcome to the 88 people who have made the journey to come here after work today. That's really greatly appreciated. My name is Caroline Fleming, and I'm one of the Paisley Committee members. Jacqueline Jones, who's just left the room, I was about to give a big thanks to Jacqueline for organising not only this live event for the 80 of you to attend today, but we reckon there's about 300 people have also streamed into this event, so we're hopefully going to manage to deliver this message to all of Scotland and anyone else who's listening. The purpose of this evening is for us to give you insight into the new requirements, which are in the new 10 not so pocket-sized handbook that has been launched live at this course. And if you were members between 2017 to 2018, you should have had an email to fill in your form to join. If you were not members then and you want to join Pine Group now, you'll get this at a reduced rate. If you don't want to join Pine Group, you'll pay a little bit more for it. And the sales will be live from July, so from July. All the delegates on the clinical update have got copies which they're clutching to their chest because they're quite sure the departments are going to thumb through them as soon as they get them. We have 2 copies here if anyone wants to have a look at them on your way out tonight. So now it gives me great pleasure to hand you over to Dr. Liz Weeks, who has come up from London. Liz has led on the group who have developed all of this work to update the requirements section, which is something that we've been long awaiting, and she's going to tell you a little bit about her work today and about the new section that's in the handbook. So thanks very much, Liz, for coming along.
I clap yet. I haven't said anything. Thank you very much for inviting me up to speak today. It's with great pleasure that I'd like to share the work that we've done on updating the chapter of the nutrition requirements bit in for the Pocket Guide, and I'm very, very glad to see it published this week. The work that we did was funded by Penn Group. So we wanted to tell you that actually this work has not been all done for free. It's actually been sorry, I've completely lost my track of thought for a second there. When you pay for your Penn subscription, you sometimes wonder what it's for. This is one of the things that has come out of it, is the work that we've done. The work that we did was led by myself, but there were a team of 5 of us who worked on it, and you will see who they all are at the very end. So why did we want to update the chapter? Well, I've been involved in writing the chapter for 20 years. And in the first instance, I wrote it on my own. And at that time, I was just a fairly junior dietitian with an interest in nutritional requirements and a tiny bit of research experience that I had when I was working at Addenbrooke's Hospital. At that time, I did a little bit of work looking at energy requirements in patients who'd had a stroke or a head injury. Because I expressed that interest, I was asked if I would like to update the chapter when it came out, when the Pocket Guide came out in 1997, I think it was. And I did it myself for a couple of editions. And then latterly, I was joined by Claire Salisbury, who some of you may know, has been a member of Penn Group, has also taught on this course, and is working in Liverpool. So the last version, which we did, was in 2011, was done by Claire and I. When we were asked this time about it, I wanted to explore whether it's possible to actually improve the way that we wrote the guidelines. Between 2011 and 2016, when we actually started this work, I had gained some experience in doing Cochrane systematic reviews, and I'd also been involved in doing a couple of guideline development programs. And I was very aware of the fact that the way we'd written the chapter in the past was quite ad hoc and not very robust. So I pitched to Penn Group that we would do a proper guideline development process, and they very kindly said yes and gave us some money. So this is what the outcome has been. So today I'm going to just start out with giving you some definitions around energy requirements so that we're all talking about the same thing. I'm going to talk about current practice and criticisms of the methods that are available. I'm then going to tell you a little bit about how we updated the guidelines and how to use them specifically for energy and protein. I'm not going to cover the other nutrients. I'm then going to tell you about some of the additional resources that we've made available for you to use and how we're going to disseminate and evaluate what we've done. Towards the end of the talk, I will introduce a case study and work through it as part of the talk. And then at the very end, for those of you who are in Edinburgh, there will be another case study for you to work through, which we will hand out to you at the end. Sadly, for those who are streaming in, that won't happen. So the first thing I'm going to talk about is definitions around energy requirements. So total energy expenditure is that energy that we expend every day doing everything that we do. And it's normally measured in research settings using the doubly labelled water technique. Can give you an indication of people's total energy expenditure over periods of up to about 2 weeks. It is expensive to do, and it requires very expensive equipment and expertise, so it's rarely done in clinical settings, although sometimes it is. But what doubly labelled water technique doesn't tell you is which components of energy expenditure are being used and which bits are not being used. And this is actually something that's quite important when you look at patients in clinical practice. So for the purposes of definitions, I'm going to say that basal metabolic rate is that energy that we expend lying still at physical and mental rest, not asleep. It's usually taken to be about 60 to 70% of your total energy expenditure. And in weight-stable individuals, it's very reproducible. Although there is between 5 and 10% variation between individuals of the same sex or age, usually to do with differences in body composition and differences in diurnal rhythms. Basal metabolic rate is extremely difficult to measure accurately because in order to do that, you need to have someone at physical and mental rest, not having had any extreme physical activity the day before, not having had any stimulants such as coffee or alcohol the day before. And if you can imagine trying to get a basal metabolic rate measurement in a clinical setting, it's extremely difficult. I've tried to measure basal metabolic rate in stroke patients on a ward, and with all the things that are going on around you, for example, someone expectorating in the unit next door or a cleaner coming round or stuff, it's very difficult to get people lying still at physical and mental rest. So basal metabolic rate is a concept that we have, but really what we measure is resting energy expenditure. That is basal metabolic rate plus any extra that might be going on because people aren't able to fulfill all the criteria for BMR. The next bit is diet-induced thermogenesis, and that's the energy that we use digesting and transporting our nutrients around the body. And it's generally taken to be about 10% of a mixed meal. However, if you have a very high protein intake, it could be a little bit more than that. If a patient is fully fasted or a person is fully fasted, then diet-induced thermogenesis is absent, okay? So fully fasted means not having had any nutrients at all for at least 10 to 12 hours, okay? And then the final component of energy expenditure is physical activity, which is the most variable component in free-living, healthy individuals. Normally taken to be 25 to 50% of total energy expenditure. And in our relatively sedentary population these days, it's taken to be about 40% above BMR. Increasingly, this component of energy expenditure is being measured using accelerometers or multi-sensor monitors or pedometers. And some of you may have seen those sorts of things being used in gyms or other sorts of settings, and increasingly they're being used in research settings. So these are the terms I'm going to be using: total energy expenditure, resting energy expenditure, diet-induced thermogenesis, and physical activity. So measured energy expenditure may or may not be the same as energy requirements. And it depends on which component of energy expenditure you're measuring. So you could measure total energy expenditure, you could measure resting energy expenditure, and you could measure anything in between if you haven't fulfilled all the criteria for resting energy expenditure. Now, the reason I'm explaining this is because when you read papers describing clinical studies where they've measured energy expenditure may be one thing or another or two different things, depending on which component they've measured. So it is important to know the difference between whether they're talking about total energy expenditure, resting energy expenditure, or energy expenditure including diet-induced thermogenesis or activity. So what I'm going to do now is talk about what current practice is in estimating requirements. Now, I've used the word estimating very specifically. One thing I want people to go away with today is that we never can calculate energy requirements because at any one time, we don't really know what someone's energy requirements actually are. Because when you look at this list, there's a whole host of things going on in any individual patient at any time that might affect their energy requirements. So if you think about it, we're not calculating their requirements, we're estimating them from the best knowledge that we've got at that particular time. And if you're going to estimate energy requirements, you should, in theory, consider all of these things because they all, to a greater or lesser degree, affect what somebody's energy expenditure might be. As people get older and they lose lean body mass, their energy expenditure might go down a bit. There's differences according to whether people are in the acute phase of illness or whether they're in the recovery phase or whether they're in the anabolic phase and able to utilize the energy that you're using. There will be difference according to their nutritional status, whether they're malnourished or not. There'll be differences depending on what kind of interventions they're receiving. So, for example, we know that some drugs can actually make people's energy expenditure go down. such as sedation in ICU, and other drugs might make people's energy expenditure go up, for example, using dexamethasone. So knowing the drugs or the treatments that people are receiving will also influence what you think about their requirements. Also, people's physical activity. Now, we don't really think about people in hospital or in care settings having a physical activity factor, but actually think about it a bit more deeply. And quite a lot of people nowadays may be going through rehabilitation, or physios are very keen to get people up and about and active as soon as possible. There's a dearth of information around what people's energy requirements are around physical activity in the clinical setting. The other thing we don't know an awful lot about is how does the pain of moving a damaged limb affect people's energy expenditure around physical activity? Do you exert the same amount of energy walking with a Zimmer frame as you do walking without a Zimmer frame? There are lots of different parameters around physical activity that we don't really know. So in terms of estimating energy requirements, we have to hold all these things in our mind to think about what we want to give to our patient. So those are all the things that happen when we're trying to estimate someone's requirements, but what methods do we use? Well, in clinical practice, there are really 3 main methods. Having said that, quite a few national and international guidelines recommend that indirect calorimetry be used in certain clinical conditions. For example, severe hepatic failure, or in obese patients in ICU. Have any of you seen indirect calorimetry being used in clinical practice? No, doesn't really happen, does it? No, it's in the recommendations, but it extremely rarely happens in this country, and I think it even rarely happens in the USA. So actually what we're left with is 3 main methods of estimating requirements. We've got the factorial method, which is what we recommended last time. We have regression equations, and we have the rule of thumb method, and I'm going to go through each of those now with their relative strengths and weaknesses. But before I start, I want to just use this gentleman as an example to apply these different methods to. So he's a typical COPD patient, 70 years old, with a weight of 65 kilos and a BMI of 20. He's suffered a little bit of weight loss. He's been hospitalized for an acute exacerbation, and he's about to start oral nutritional support. He's mobile on the ward, and before he came into hospital, he was consuming 1,700 calories a day. And while he's in hospital, he's consuming 1,300 calories per day. So the factorial method, which is the method that's in the old version of the Penge pocket guide, is based on the underlying principle that you use a basal metabolic rate prediction equation, the Henry equation, derived for healthy populations, and you adjust for illness in individuals by adding various factors. And you're probably all familiar with this idea of estimating BMR using the Henry equation, and then adjusting for metabolic stress and adjusting for activity and diet-induced thermogenesis, and then possibly adding or subtracting for weight change. Yeah, everyone's familiar with that, I hope. If you use this method with this particular gentleman, you get an estimated requirement of around about 1,900 calories per day. But this method is open to criticism. The first thing is the underlying principle is fundamentally flawed. BMR equations, prediction equations derived for healthy populations possibly shouldn't be used in sick individuals. The majority of the clinical studies that we've seen when we were doing our searching actually compared measured energy expenditure in clinical populations with the Harris-Benedict equations. Now, I don't know how many of you are familiar with the Harris-Benedict equations, but they were published in 1919. They were published 100 years ago, and they were on a population of young, fit, lean individuals. Yeah, how applicable are they to possibly fairly ancient, not so lean, sick individuals? Not at all. Yeah. But having said that, you will see an awful lot of clinical studies that compare measured energy expenditure to the Harris-Benedict equations, particularly in studies that have been undertaken in the USA. So that's the first criticism. The next criticism is that we got fed back to us that quite often people were using inappropriately high stress factors from the table that we had put in the previous version of the handbook, and that were possibly overfeeding patients as a result of being slightly inexperienced and maybe giving people stress factors of 40 or 50 or 60%, when probably that wasn't appropriate. The other thing that we weren't able to capture, and we have tried to do this time, is some of the studies that we included last time were relatively old, from the 1980s and 1990s. Now, I've been in the NHS for 30 years, and clinical practice in a lot of conditions has changed enormously in that time. In that time, burns have been managed, now are much more managed in thermoneutral environments. People have a lot quicker excision by surgery of their burns, and they are treated in a different way so that the metabolic response to having a burn is much lower now than it was 30 years ago. So using a paper from 30 years ago may not actually be appropriate because clinical practice is different. Similarly, thinking about HIV infection, 30 years ago, HIV infection was a very different disease from what it is now. People were acutely unwell, very malnourished, and had a much shorter lifespan than they do now. And so applying the sorts of studies that we might have picked up from the 1990s to patients nowadays might be inappropriate. The other final criticism of PEND recommendations is that it uses measurements like height and weight that are static, but also quite difficult to manage, to get hold of in the clinical setting. So if we don't use the factorial method, what other methods are available to us? So the next one is disease-specific regression equations. And the underlying principle for these is that you use a combination of static measures like like gender and weight, and physiological parameters like temperature and stuff to estimate requirements in specific populations. And those of you who work in ITU or in burns might be familiar with the Ireton-Jones regression equations or the Pennsylvania state equations. Disease-specific regression equations are derived from clinical studies. So they measure lots of people. They calculate what the what the mean was for that, and they look at different parameters to see what best predicts people's energy requirements in a specific clinical population. This has most often been done in intensive care, but we have found a few other regression equations in other clinical conditions. The best studies will derive their equation and then test it in another population to make sure that it does predict as well as it say it does. That's a test of validity, but actually not everybody does that. So they are available. We found one for COPD, and I'm just putting, I know it's old, but I'm putting it in for illustrative purposes just for this gentleman. And if you use this particular equation for him, you come up with an estimate of around about 2,000 calories. So not too different from using the other method. The criticisms of this method are that at the moment, we have no guidelines for how frequently you should recalculate your requirements in the light of any changes in those physiological parameters. So if someone's temperature changes 3 or 4 times over 2 or 3 days, do you have to keep recalculating the requirements if temperature is part of that regression equation? There's also no evidence at the moment that amending a feeding regimen in response to changes in these variables makes any difference to outcome. It would be an extremely difficult study to do, so that's why there probably isn't evidence out there. And as I've also mentioned, a lot of the studies are open to criticisms regarding their validity. Have they actually tested the regression equation in a separate population and their applicability to individuals? All of the methods that I'm describing are very good for predicting requirements for groups of people, but they're not very good at predicting requirements for individuals. So the final one is the rule of thumb method. And the underlying principle for this one is that there are estimates, you estimate requirements for energy on a value per kilogram body weight or per kilogram fat-free mass, or in older studies per kilogram lean body mass. And these are quite often recommended in national and international guidelines. So you might be familiar with the NICE guideline, where they recommended 25 to 35 calories per kilogram body weight per day for people not at risk of refeeding syndrome. And there are ESPEN guidelines and ASPEN guidelines for specific conditions that use this method. These rule of thumb formulae are originally derived from clinical studies where energy expenditure is measured in a specific population, hopefully under standardized conditions, okay? And as I say, they're recommended a lot in international guidelines. So if you were to apply the NICE guidelines for this particular gentleman, you'd get a range of between 1,600 and 2,300 calories per day for that gentleman. The criticisms of this method, of course, are that there are no defined criteria for when you might use 20 calories per kilogram body weight, 25, 30, or 35. Also, when you read the guidelines, it's not very clear, quite often, whether they're recommending that this is a calculation for resting energy expenditure or total energy expenditure. Now, I suspect that the 20 to 25s are often resting energy expenditure and the 30 to 35s are total, but it's not very clear quite often. It's also unclear for people who are obese or underweight whether their requirements should be calculated using their actual or ideal body weight using this particular method. And there's quite a lot of discussion about whether you should use actual or ideal body weight or a percentage of the body weight in obese or very thin individuals. And the evidence is still very unclear about what you should use. And the final criticism of this method is that it doesn't account for changes in energy requirements that might be due to differences in age or gender, metabolic state, or any of the other things that are going on with a patient. So all three of those prediction methods might over or underestimate a patient's requirements in comparison to their measured energy expenditure. They are often inadequately validated, and I hold my hands up and say very clearly that our guidelines last time were inadequately validated. While each method might have a good predictive value for groups of patients, all of them have poor predictive values for individuals. They're open to misinterpretation with the potential for clinical consequences of over and underfeeding. Every single one of these methods requires clinical judgment. So we're not asking people to do anything new now. We've always had to use clinical judgment. We're just, in this new chapter, being much more explicit about the role of that. So if that's the criticisms, what should we be doing? Well, I'm going to tell you how we updated the guidelines first, and then we'll talk about what they've come up with. But before I start, I just want to remind you what a guideline is. They are recommendations that are intended to assist you in making healthcare decisions. And they are based on the best available evidence. Now, that is a really crucial point, because a lot of the guidelines that you see, and actually in two sets of guidelines I've been involved in, the best available evidence was really not that great, okay? So you can have a very beautifully written guideline, but if the evidence that underpins it is not that great, don't pin much clinical judgment on that, okay? Be aware of the limitations. And part of this talk, and part of all the talks I'm doing, is to make you aware of the limitations of the guidelines that we've written. So what is the best available evidence? Well, you're probably all very familiar with this kind of hierarchy of evidence, going from expert opinion through case studies, case control studies, up through randomized controlled trials and systematic reviews. Last time when we wrote the chapter, Claire and I think we were at the bottom of the pyramid. It was our expert opinion. Hopefully it's a little bit further up the pyramid this time. Having said that, it's nowhere near the top. Okay, because the quality and the extent of the evidence is still quite lacking. What I would say is you can be critical of anything along this pyramid. You can even be critical of randomized controlled trials and systematic reviews. There are good systematic reviews and there are bad ones. There are good RCTs and there are bad ones and everything in between. There are good guidelines and there are bad ones. So one thing I would like you to take away from today is to be critical of everything that you read. So I'm now going to talk about how we did the energy requirements searching. So what we did is we did 5 brand new systematic reviews of clinical studies where energy expenditure was measured using validated methods. And what you will find in the back of the chapter is a clear description of what we meant by validated methods. And we were looking specifically at what the requirements would be in clinical studies in patients who were either metabolically stressed or metabolically stable, at the extremes of BMI, i.e. less than 18.5 or more than 30. And we had a separate question in about long-term nutritional support in neuromuscular conditions because we got so many questions about that. In order to do the systematic reviews, we had to define what conditions we were looking for in terms of resting energy expenditure, total energy expenditure, and physical activity. Okay? And we limited our searching to studies in patients likely to require nutritional support. Now, that is a really important point because we became aware last time that people were using the Pocket Guide right across the dietetic profession for all different reasons, for patients requiring therapeutic diets or all sorts of things. These are specifically written for patients requiring nutritional support. We didn't look for studies that were looking at patients with diabetes or that sort of thing, or people who required weight reduction or people who required lipid-lowering diets. When you see how many papers we had to plow through just to do nutritional support, you'll see why we didn't do the others as well. You're very welcome to do those for yourself, but we didn't do them. So that is something to remember. It is purely for patients requiring nutritional support. We looked at 5 databases and we did lots of hand searching and all sorts of stuff, but we did exclude some specific conditions. We excluded intensive care because that chapter was being written by other people and they were looking at nutritional requirements in there. We excluded anorexia nervosa and obesity syndromes unless the patients were requiring nutritional support. Okay? So not if they were just obese or very thin, they had to be requiring nutritional support. And we excluded studies for HIV patients prior to the advent of antiretroviral treatments because we felt they were inappropriate. So older studies weren't considered necessarily appropriate. And as a result of all this searching, we got more than 43,000 titles and abstracts that we had to have reviewed. Each one was reviewed by 2 different people, and then we had to decide between those 2 people what needed to be looked at in more detail. And from those 43,664 titles and abstracts, we got just over 1,000 papers that we looked at. Of those just over 1,000, 500 actually met all the inclusion criteria. The sorts of things they got excluded for if they didn't meet the inclusion criteria was, although they talked about energy expenditure, they never measured it, or they used methods that were not valid or reliable. Some studies were in children or included children, and we couldn't take the children out, or they were in conditions that we had already excluded. So of those 500 studies, we got 36 systematic reviews, and we got just over 300 studies, which are circled at the bottom, where they were clinical studies in patients requiring nutritional support where the patients were fully fasted. So what they were reporting was resting energy expenditure in clinical settings. And the requirements chapter is based on these 300 papers mostly. Of all those studies that we had, more than 90% reported resting energy expenditure. There was very little information on physical activity, DIT, or total energy expenditure in clinical settings. We got information on more than 30 different disease states, and to the right you can see the most common ones. They went right across the different care settings. So it wasn't limited to hospital. We had hospital outpatients, inpatients, rehabilitation units, and nursing homes. But surprisingly and disappointingly, a significant proportion didn't tell us the weight, the BMI, or the nutritional status of the patients. Some of them didn't even tell us the gender or the age. And very few of them reported clinical parameters that might give us some indication of the metabolic state of the patient. Now, if you're making a clinical judgment about the metabolic state of a patient and you're looking in a paper that hasn't told you anything about that, that seriously limits what you can do with it. So this is what the chapter looks like. This is the beginning. And as you can see, we've made it very explicit that this is a chapter for use in patients requiring nutritional support by whatever route. We've also said estimated requirements are a starting point only. You're never going to calculate someone's actual requirements, you're just going to get a ballpark figure. And you need to use your clinical judgment and monitor your patient to make sure whether you're meeting their goals. So probably what we should have put in here, which I've been thinking about quite a lot, is establish nutritional goals, estimate requirements as a starting point, and then measure, okay? So what we also say at the beginning of the chapter is we advise people to use the flowchart and the tables, which I'm going to show you in a minute, only after you've read the accompanying text. And the reason why we say that is because the accompanying text tells you an awful lot about how to use the flowchart. So we have a process where the recommendation is that you establish your goals of nutritional support. What are you hoping to achieve in the first stage? Then there's a 4-step process, which I'm going to show you in a moment, that uses a flow diagram and some tables. We explicitly say that this process requires the use of your clinical judgment throughout and requires that you monitor your response to treatment. So this is what it looks like. So the first step is gathering information on the patient's nutritional status, including measurement of their actual body weight or fat-free mass, and any other relevant data such as their age, their diagnosis, the degree of metabolic stress, and their current intake. The next bit is to determine their body mass index, and then you can use a table that I'll show you in a minute to estimate their resting energy requirements. If their BMI is below 18.5 or above 30, there's a separate table for you to look at. So what we ask you to do is to estimate their resting energy expenditure from their body weight, and you multiply it by a calories per kilogram body weight method. So we're using a rule of thumb formula, okay? And when you look at the tables, and there are pages and pages and pages of them, you will see that actually there are quite a few gaps. So we have made a recommendation that if you are looking for a patient and you can't find the clinical condition or the BMI or whatever that applies to them, if their BMI is between 18.5 and 30, we say estimate resting energy expenditure using 20 to 25 calories per kilogram body weight. And this is what the table looks like. And what you can see is it's divided down the left-hand side, it gives you the disease state. And then you've got 6 columns. The first 2 columns refer to patients with a BMI of less than 18.5 and age below 65 and over 65. The middle 2 columns relate to people with a BMI between 18.5 and 30. And then the last 2 columns refer to patients with a BMI of over 30. And then there's some comments, and we then list the studies that we've used to give you the information. And then you'll see that there are some numbers. I'm going to try this. Here, yeah, with little letters next to them. So the number is the mean of all the studies, the mean of the means of all the studies, okay? Now, if there's only one study, you'll only get one number. If there's several studies, you'll get one number with a range of the means underneath. And then you'll get the little letter, and the letter tells you the quality of the study. A means that the patients were fully fasted and it's a good quality study, and it goes all the way through down to D. Okay? And where there's a lack of evidence in any other place, we will sometimes put Ds in. Okay? So you'll see that up here there's a D there for acute kidney injury. You've got A's here for COPD. But you'll also see that in some conditions, there's no information at all. Now, that doesn't mean to say there were no studies in those conditions. It means that the studies didn't report the data in the way that we could use to put it into the table. So what we have done is we've provided some online resources, which I'll show you a little bit later, what they look like, for you to be able to get some feel for what's going on in those patients. And what we've also done is put these comments. For example, they might have been in a study where they've measured patients' metabolic state and noticed that those with increased rates, for example, of TNF-alpha, are patients who are more likely to have a higher energy expenditure. Okay, so where we've got information that is more than just a number, we've given it to you. But the thing that you will see here is a huge number of gaps, massive number of gaps, particularly in patients with BMI of less than 18.5 or over 30. That's because we just couldn't find any evidence, all right? We couldn't find studies that looked at those. So, as I've said already, we were unable to include quite a few studies because they didn't report the data in the right way. And as I pointed out, there's a lack of studies at the extremes of BMI. The other thing to remember is quite a lot of the studies, when you read the inclusion criteria or exclusion criteria, they excluded people with evidence of an infection or other catabolic conditions. So they were excluding the sickest patients. Now, the figures are the weighted means. So what I'm saying about that is if we go back, this is the mean in the study, say 19, but actually the range around that mean might have been enormous. It might have been as low as 12 or 13 up to 30. So you're getting means of means. So, but the range in all these conditions is very, very wide. So this is why we're saying it's an estimate. It's not going to give you the exact answer. And most of the figures in table 3.1 represent resting energy expenditure. Okay, so that is in the fasted state, unless we state otherwise, and it will have a little C or a D next to it. So resting energy expenditure is the lowest amount of energy a person is likely to need. Okay, it doesn't include physical activity, and it doesn't include DIT. Now, for some patients that might be appropriate, but for a lot of patients it won't be. So what we've done is we've given you a table that will help you assign a combined factor for physical activity and diet-induced thermogenesis. And this is the table here. Now, what you will see at the bottom of this table, and you will quite often see throughout this chapter, is a little phrase here: PEND requirements guideline group consensus opinion. Lowest quality evidence there is. Because we couldn't find evidence to tell you how much you should give for physical activity and DIT, we went through a formal consensus process of discussing it and pulling the papers together and everything, but it is our opinion, okay? This is just our best guess of what we can get, what we can recommend for physical activity and DIT based on the limited evidence that was there. So this is the physical activity factor that you would multiply your resting energy expenditure by to get your total energy expenditure for your individual patient. So for most people who are acutely unwell, it will be between 1 and 1.1. If they're in bed or sitting out, 1.1 and 1.2, and all the way up to, if they're sedentary, it might be up to 1.4. What we've tried to do is give you some examples on the right-hand side. We were originally asked to look at which care settings people should be assigned which physical activity levels. And we realised that actually it's not to do with the care setting, it's to do with the physical activity of the patient. So you might have a patient in hospital who's actually actively having a lot of physio and who would be using a lot more energy physical activity energy than someone sitting at home doing nothing. So what we've tried to do is give examples that cut across settings, okay? And so that's what we've, that's the main principal way we've had of using the flowcharts and the tables. Now, because we found an awful lot of studies where actually they reported the energy expenditure in terms of fat-free mass, okay? Because fat-free mass is a better predictor of people's energy requirements than their actual body weight. It's the metabolically active tissue. So there are quite a lot of studies where they gave us resting energy expenditure in calories per kilogram fat-free mass. So you can use a separate table to do this if you do routinely measure fat-free mass. Now, we're not at the moment recommending that everyone should do this, but it is there for those clinicians who do routinely measure fat-free mass, but with some caveats. And the caveats are that you should not estimate fat-free mass, you should measure it, because there are some ways of estimating fat-free mass out there, we found them. And what you need to be aware of is if you're going to use that table, you should look at the studies which we've listed and find out how they measured fat-free mass there and try and reproduce that. Because measuring fat-free mass, for example, by BIA, is not the same as measuring fat-free mass using full skin folds. And I think you've done your anthropometry, haven't you, already? Is that right? Yeah? No, different group. Okay, no, they haven't. Okay, fair enough. Anyway, so what I'm trying to say here is if you're going to use that, make sure you use a similar measure if you can. Although being aware that all of the ways of measuring body composition have their own strengths and limitations. So it's only to be used carefully. So that's the way of estimating requirements in people with a BMI of between 18.5 and 30. We then have a table like this that gives you some recommendations for those with a BMI of less than 18.5 and those with a BMI of over 30. And as you can see on the right-hand side, there are quite a few HEND requirements guideline group consensus opinions here, yeah, specifically for patients who are with a low BMI or for those who are metabolically stressed and obese. That's because we could find virtually no evidence to say what you should give to these patients. There is one systematic review by Choban looking at obesity, feeding obese hospitalized patients, and that's the one that we've used most of all. And there's also Angela Madden's systematic review for obese patients from 2016, and they both recommend using the Mifflin-Saint-Jean equation for estimating requirements in obese patients. But it's still very unclear whether when you're feeding a metabolically stressed obese patient, whether you should be underfeeding, whatever that means, feeding to their estimated energy, resting energy expenditure, or giving them a little bit more. We still don't know the answer to that. So this is where monitoring is really crucial, and discussing and using clinical judgment is absolutely crucial. So that's estimating energy requirements. I'm going to talk a little bit now about protein requirements. So at any one time, our body is in a constant state of flux regarding our protein requirements, depending on our current and recent dietary intake of protein, our ability, the balance between protein synthesis and protein breakdown, which will be influenced by a lot of things, such as physical activity, gender, metabolic state, and our ability to excrete protein. So again, like energy, we never know at any particular time exactly what someone's requirements are. Again, it is an estimate, and it only ever is going to be an estimate. And this is what the chapter looked like before. We're in the olden days. I did qualify 30 years ago, and in the olden days, we used to do everything in grams of nitrogen, because this used to come from how we used to make up TPN bags in the olden days, basically. So the old requirement guidelines were based on grams of nitrogen from a very old study published in 1990 by my former supervisor, Marina Celia. with some caveats about what you should do for people who with a BMI of over 30 or a BMI of over 50 kilograms per meter squared. And this is because when you put on weight, a lot of weight, you don't necessarily put on muscle mass, you put on fat mass as well. And so the metabolically active protein requirement bit is a smaller proportion of your total body weight than it would be if you had a lower BMI. So we did a similar sort of process for protein searches, although what we didn't do is we didn't look at original studies for this, we looked at guidelines. We did a systematic review of guidelines, and it is possible to do that. And if anyone's interested in doing it, there's a very nice study down there that shows you how to do it. And the reasons we did that were twofold. First of all, we ran out of time, so we couldn't do the full thing like we do for energy. And secondly, because there actually are not very many original studies in protein requirements in clinical settings, especially not recently. Having said that, we found over 200 clinical guidelines that at some way or another mentioned protein. And they were in more than 20 different clinical conditions. But we excluded 187 of them because they weren't actually clinical guidelines, some of them, although they said they were. And some of them, they didn't actually review protein requirements. And some of them, they were in patient populations that we had already excluded. So we ended up with 16 guidelines out of over nearly 3,000 titles. And this is what the protein requirements section looks like. So it's similar to the energy one. On the left-hand side, it gives you the clinical condition. The next bit gives you the recommendation. Then you get details about the reference that it came from. Then you've got a very interesting column that tells you what they base their recommendations on, the nature and the extent of the studies that they quote. And we also have given you some comments on the guideline process to give you an indication of whether it's likely to be a good guideline or not. So, for example, if you look at this, this is the ESPEN guidelines for parenteral nutrition in liver patients. And you can see at the top here that they very clearly make recommendations that for people who are malnourished, without malnutrition or moderately malnourished, they need 1.2 grams of protein per kilogram body weight. And if they're severely malnourished, they need 1.5, yeah? If they have alcoholic steatohepatitis. That is based on no studies whatsoever, okay? You're in a slightly better bet if you've got cirrhosis and you're receiving parenteral nutrition. They make similar kinds of guidelines, but that's at least based on 11 randomized controlled trials. And in people with acute or subacute liver failure, the recommendation is based on some pretty dodgy stuff. Okay, so we put that in to give you an indication of the fact that there's not a lot of really good quality evidence out there, all right? And people are writing guidelines based on this. Be aware of that. And I'm going to just go through protein requirements in older people as an illustration of the dodginess of some of the evidence. So we probably are all quite aware of the idea that people say in older people, you have a decreased protein intake generally, decreased ability to utilize the protein that they eat, and as a result, older people require more protein in their diet, especially if they're at risk of sarcopenia or anything like that. So I'm going to give you the information that we got on the protein requirements in older people. Of those 16 guidelines that we've included in our chapter, 2 refer specifically to older people. And one, the ARANTS, which is the ESPEN guideline for cancer, refers to one of the other studies. And for obese hospitalized patients, there's nothing about protein requirements. And we found no guidelines at all for patients with a BMI of less than 18.5 regarding protein for older people. The 2 that there are Bauer and Deutz. Now, Bauer is the only one that actually is original research, kind of. Deutz just refers to the Bauer one, and the Bauer one is Protage. Everyone's familiar with Protage? Yeah, quite a few people, hopefully. It's quite often referred to as the study that tells you that you must give people who are older and sick more protein. Now, the way that they came up with this guideline is that they had an international group of experts who used what's called a Delphi-like process to achieve consensus. And what that means is they sat down together or electronically away from each other, and they decided what questions they were going to ask. They went away and looked at the evidence, and then they came back, and then they got people to vote on what the recommendations should be. And they had several rounds of voting about what the recommendations would be. And they covered 5 topics: the protein needs in older people in good health, poor health, and the role of exercise and things. The big problem with this particular guideline is they didn't do any systematic reviews. And it's very unclear how they identified or selected the studies that they included. So they've listed them all, but we have no idea how they decided which studies to include. But having said that, they make some very strong recommendations that if you've got acute or chronic illness and you're older, you should have 1.2 to 1.5 grams of protein per kilogram body weight, or up to 2 if you are severely ill or have marked malnutrition. But actually, when you look at the evidence, it's in a really mixed bunch of patients. It's in mixed clinical populations, it's in critical illness, it's in hip fractures, it's in osteoporosis, it's in diabetes and chronic kidney disease. Now, are those all comparable? Probably not. And I'm just going to refer you to the evidence around the requirements for acute illness. This is what the evidence is based on. It's based on 3 studies. One is a systematic review, and the systematic review didn't look at what people's protein requirements were. It looked at if you give people an ordinary protein-containing supplement and a higher protein-containing supplement, do you have better outcomes with the higher protein-containing supplement? Now, you do. You get a significant reduction in complications, but it doesn't tell you how much protein to give to patients. It just says higher protein is better, possibly. So the only 2 studies that we've got really that measured it are Gaillard 2008 and Murray 2006. At Gaillard, they looked at how much protein did people need to take to achieve neutral nitrogen balance in older hospitalized patients. And that was done in 36 older hospitalized patients. And they came up with 1.3 to 1.6 grams of protein per kilogram body weight. In Murray, they looked at nitrogen balance studies comparing usually aging older people with healthy young adults. Now, can anyone tell me what a usually aging older person is? I hit 60 this year. Am I a usually aging older person? I have no idea. But this study wasn't conducted in a clinical population. It was conducted in a small sample size of 15 people usually aging. What on earth does that mean? And this is what this recommendation and these guidelines are based on. Pretty poor evidence, isn't it? So what have we said to do? So at extremes of BMI, we've said use our consensus opinion because we couldn't find any evidence that really was strong enough to do anything more than just give you this rough idea. And use the tables of the 16 guidelines that we've included, but be very aware of the lack of evidence to support a lot of them. So let's go back to my gentleman who we started with at the beginning. He is your typical COPD patient with an acute exacerbation. What would we do with him? Well, obviously, we've got all the information about his nutritional status. He's a bit depleted. He has a fairly okay BMI, but he's lost a fair amount of weight. He's not eating very much. So we're going to estimate his resting energy expenditure using the table, okay? And I'm just highlighting that for the moment, because if you look at the table, for COPD, acute exacerbation, there are no studies, okay? So you have to go back and use the generic recommendation, which is between 20 and 25 calories per kilogram body weight, yeah, for him. And then you think about what are you going to give him for his physical activity level. probably limited mobility, yeah, something between 1.2 and 1.25 calories per physical activity level in DIT. So what that comes out at is on this table. So if you were to use our previous method, which is the Henry equation plus fudge factors, you'd come out around about 1900 calories, which I covered at the beginning. If you were to use our current method, you'd use 20 to 25 calories per kilogram body weight, and you might give them a 20% power. So that gives you between 1560 and 1950 calories per day. So what we're saying now is have a range in mind, okay, which a lot of people probably already did, but it depends on what else is going on with that patient. Now, what else do we know about him? What would you give him? Someone tell me what they give him or aim for. There's no right answer, no wrong answer. Tell me what you do. Nobody want to hazard a guess? Well, he was eating 1700 calories before he came in, and he was losing weight on that. He's eating 1300 calories now. But if he's eating 1300 calories now, and his estimated requirements are between 15 and 1900 calories, you probably want to aim for something like 1700 calories, on the understanding that he'll probably consume it, but it won't be sufficient for him to put on weight. Yeah? What I'm trying to say to you here is it really depends on what else is going on with that patient. Now, we've always done this. We've always used our clinical judgment, but I think people have tended to think that the tables in the old guidelines told you what to do. They didn't tell you what to do any more than what this does, all right? Or any less than what this does. So I personally would give that guy, I'd aim for 1700 calories, and then when he goes home, I'd make sure he was getting 1900 to 2000. But that may or may not be right, but I would monitor him. And you can see that if you look at the other guidelines, like the NICE guidelines or the Aspen guidelines, or using the regression equation, you're going to get something fairly similar for the regression equation, but a huge range for the other guidelines. But we've given you a range as well. And the reason we're getting people to calculate a range is because people's requirements vary with what's going on with them at that time. And in terms of estimating protein requirements, if you were to use our old guidelines, his requirements would be between 65 and 130 grams of protein. And if you were to use our new generic guidelines, it would be between 65 and 98. If you were to use Bauer, it would be 78 to 98. And if you were to use the NICE guidelines, it would be 52 to 98. What was he eating? Quite a lot less than that. Aim for a bit more, right? I think one of the things I want to get across is don't get too hung up on the calculation. It is an estimate, and it's a thing that needs to be monitored. So when you look at your chapter, when you get the handbook, there are some worked case studies, but they are there to give you a guide of some of the questions that you might need to discuss or think about. There is no correct answer, and the examples are the suggestions of those of us who are in the requirements guideline group. And if you had heard all the discussions and the conversations we had at trying to come to a consensus between us for each of those case studies, you'd realise that there are no right or wrong answers. So in the chapter now, you have additional information, and there are specific sections on patients with fluid overload, amputees, patients with burns, and neurodisabilities. So they're not necessarily all included in the tables. Obviously, there's the fluid and electrolytes bit and the micronutrients bit, and the tables of compositions of secretions and all that stuff that used to be in there before. And some things have been updated, but there's still, you can see, a fair amount of relatively old evidence there because there's not much been updated for that. Now, today, I'm announcing that we have also provided some online resources for you all. And this, for those who has a penned handbook, it's to provide additional material to help you estimate requirements in those conditions where all the gaps were. So they were papers that were identified as part of our searches. but they couldn't be included in the tables because they didn't report the data in the right way. So rather than just leaving all that data in our brains or in the suitcase that's in my front room, we thought we'd put it online for people to use how they want. So there are two resources. One is about disease-specific regression equations, and the other one gives you information about resting energy expenditure, total energy expenditure, and physical activity in a number of clinical conditions that we got some information from. And that is going to be the website that you will be able to access with a password that you will get when you buy your pocket guide or get your pocket guide. And this is what they'll look like. So this is just an example from the disease-specific regression equations. And what you will see here as the clinical condition, again, is on the left. Gives you some description of the population. It tells you what the regression equation is. And then it tells you whether they actually tested it, whether it was valid or not. And then it tells you any extra comments that might be there. So you'll see, for example, the Ayrton Jones one is there, and there's one from our colleagues in Amsterdam, from Hinke Krausenger on the right. And you will find in the tables in the handbook and also in the online resources that for patients where you are not sure what to give them, you could use these mixed populations of surgical inpatients or outpatients, or you could use, there is one which makes guidelines for polymorbid patients. So there are stuff in there for people with more than one clinical condition. And I know that people have been asking, well, they've got 16 clinical conditions, what am I going to do? There are some recommendations in there as well. So they'll either be in the online resources or in one of the tables. And this one is an example of resource number 2, and it relates specifically to COPD. And what we've done again is we've talked about what they've measured, who they've measured it in, and given you some information about the patient's age, their BMI, their gender, if they told us, and their weight. And also we then have got things about their resting energy expenditure, their physical activity, or their total energy expenditure. So if you've got nothing else at all, you've at least got some information there, and you can see if your patient fits into one of these groups. So we've given you all that information so you can say, well, that looks a bit like my patient, okay? If you can't find anything in the tables in the pocket guide itself. So the pocket guide, as we all know, has been launched yesterday, I think. The online resources, as I say, will be available for those who have a pocket guide when you will get a password. We have been going around doing national and local study days to familiarise people with the methods that we've used and the new guidelines. We're very happy to do that and to continue doing that. We divvy it up between myself and the other members of the team, depending on locality. What we're not really able to do is to do individual departments, unless you've got an awful lot of people in your department. We prefer like branch study days or special interest group study days, just so that we get bigger audiences, because actually it's quite a lot of travelling around. Claire and I are leading on writing a couple of papers around this. We sent a survey round on SurveyMonkey through the BDA earlier in the year in April to find out what people are doing at the moment. And we got more than 400 replies to that. We're analysing that at the moment. And we're then going to redo that survey in a year's time to see whether practice has changed in any way and what kind of comments people have about the new methods. Because if you're finding it totally impractical and difficult to use, we need to know. Okay? And that's part of the guideline process. So, in conclusion, the main points I want you to take away are estimated requirements are a starting point only. Your clinical judgment, your setting of goals and monitoring are all crucial parts of the process. We have used a systematic approach to identify, collate and review the clinical studies and the guidelines, but be aware of the limitations of some of the evidence. We've presented a variety of methods for estimating requirements, and you should now be familiar with the relative strengths and weaknesses of the ones that are out there. But the final thing is to remember that it's our own individual responsibility as clinicians to ensure our practice is supported by evidence. And I would say never blindly follow guidelines of any sort, including these, and critically appraise all the evidence that you encounter, because there is a lot of talk that goes on about the evidence says this, the evidence says that. When you actually look at it, quite often it doesn't say very much. So be aware of that. And finally, I would just like to acknowledge the wonderful team that I worked with on this. That's Bruno, who you'll all see here, Claire Soulsby, Joe Cope, who's also on this course, Danielle Judges from Kent, Alison Culkin, who did the fluid and electrolytes and micronutrients bit, and my colleague Christine Baldwin, who I work with in London, who advised on the review methodology. So it was the work of a lot of people. And we now have our weekends back, so we're very grateful for that. And I'd like to finish with any questions. Thank you very much.